My name is Janos, Tanyi, and I am an associate professor of the Department of Obstetric and Gynecology and the Division of Gynecological Oncology at the University of Pennsylvania. Most of the ovarian cancer patients, when diagnosed, is already in advanced stage. Over 70% of those patients in stage 3 and 4, where the disease is all over in the abdomen or even in the chest. And ovarian cancer, not just one single tumor lesion. This is hundreds of small tumor lesions or carcinomatosis and lots of fluids. So one of the biggest challenge, how to remove or debug or decrease the amount of the tumor burden, and decrease down even to no evidence of disease, combining surgery and chemotherapy. All right, this study was a phase 3 study evaluating this safety and efficacy of paflossacin sodium, another name OTR-38, for intraoperative molecular imaging during cytoreductive surgery of folate receptor alpha positive ovarian cancer. So this is well known that our ability as surgeon to achieve complete cytoreduction, this is well known that our ability of surgeon to achieve complete cytoreduction impacts on the survival and the prognosis of our patients, and survival enhanced on those particular patients where we can reach R0 cytoreduction, so no residual disease left behind. To achieve complete cytoreduction, it relies upon the accurate detection and, if possible, removal of all tumor lesions. And today, surgeons, surgical oncologists and gynecological oncologists has two instruments to reach this state: the visual inspection during the surgery under the white surgical light and manual palpation to identify and remove all the tumor nodules. But there are limitations of this approach because we can overlook lesions, mostly if they are small in size. So the surgeon requires some help to augment this process and identify lesions. And the application of intraoperative real-time fluorescence molecular imaging using tumor-specific agents are under development in the United States and many other places in the world to address this particular need. In our study, we targeted folate receptor alpha, which is overexpressed in many solid tumors. Folate receptor alpha, per a couple of publications, is overexpressed 97% of the high-grade serous ovarian cancers on a moderate and high level. And by the same publication by Marquette and colleagues, normal ovary does not express folate receptor alpha or has a very limited folate receptor alpha expression. So OTR-38, our agent, is a folic acid analog conjugated with an indocyanine green dye, and this is a perfect tumor-specific agent that we can use for folate receptor positive cancer surgeries. In this particular study, our primary objective was to avoid the efficacy. So how many percent of the patients we are able to identify one or more additional lesion using OTR-38 and near-infrared intraoperative real-time imaging, which was not identified with visual observation and manual palpation on tissue, which was not planned for removal. The study was conducted between March of 2018 up to April of 2020 in 11 tertiary care cancer centers, 10 in the United States and 1 in the Netherlands. Altogether, 150 patients received the full OTR-38 dose, and these 150 patients comprised the safety analysis set. In this particular study, the patients serve as their own control, which means we compared the surgical plan before and after intraoperative molecular imaging. So at the morning of the surgery, the patient received an OTR-38 infusion, and in the OR, the surgeon, after opening the abdominal cavity, evaluated and documented all suspicious lesions just with normal white light, visual inspection, and manual palpation. And thereafter, an intraoperative molecular imaging happened in the OR. And the surgeons again documented all fluorescence lesions, all suspicious lesions documented. And this particular time, the surgeon had the ability to change the pre-fluorescence surgical plan. After the surgery was conducted, and once the surgery was completed, we did another intraoperative molecular imaging to identify all lesions which was overlooked or left behind. All single tumor lesion and tissue samples which were removed were sent to a central pathology laboratory in the Moffitt Cancer Center for hematoxin elsin staining and for folate receptor alpha immunohistochemistry. So in this particular study, as I mentioned, the primary endpoint was the efficacy. The secondary endpoint was the assess safety further, and also the false positive rate and the sensitivity. This particular study met with the primary endpoint, which was 33%, which means that 33% of our patients, we were able to identify one or more additional tumor lesions, what we were able to identify with OTR38 and a near infrared intraoperative imaging, and was not identified by visual inspection and manual palpation on tissue which was originally not planned for removal. It was very interesting that this percentage changed by the surgery type. Interval debulking surgery, this percentage increased to 39.7%, and in primary debulking surgery, it was 17.9%. The secondary endpoint sensitivity in this study was 83%, and the false positive rate was 32.7%. We performed the post-hoc analysis and evaluated those surgeons' outcome who performed more than 5 intraoperative molecular imaging, and we found that the sensitivity increased to almost 87%, and false positive rate decreased to 28% in this particular study amongst those surgeons who were more experienced using this technology. We evaluated the false positive rate by the request of FDA because removing fluorescence but tumor not containing tissue can increase the surgical risk. We evaluated our patient population compared to the literature, and we found that removing false positive tissue, which is fluorescence but does not contain cancer, did not worsen the surgical risk in these particular patients. We also evaluated the safety profile of OTR38, and no new safety signal emerged. The most frequently seen side effect was abdominal pain, nausea, vomiting, occasional headache, which all resolved within 24 hours without any medical treatment. And 97% of these side effects were mild or moderate. So the clinical implication, we surveyed the investigators in this study and asked their opinion about the intraoperative molecular imaging. And the investigators reported that 56% of them changed the pre-fluorescent surgical plan after intraoperative molecular imaging. 50% of them reported that they did more complete cytoreduction, and 62.8% reported that they reached R0, no gross residual, so R0 complete debulking with this technology during the surgery. So folate receptor alpha is overexpressed in many solid tumors. I think this agent is already FDA approved by FDA approved for ovarian cancer, and recently the lung phase 3 study also completed, so we are very eager to see the results. But as many solid tumors express folate receptor alpha, I think the application of pofosylcyanin sodium combined with intraoperative molecular imaging can be applied for other solid tumor debulking surgeries, identifying further lesions, make those surgeries more complete. So I think this will be much more spread and widespread application within a couple of years on the field.